Okay. Are we audible?
Saad bhai, can you hear us?
Are we audible?
Khalid, do I have a choice?
No, not today.
Assalamu
So
alaikum.
we'll go ahead and present the
We can
case.
see you and we can see the film
Okay,
at the
good.
moment. I mean, like your scope, and we have the EUS.
And that image of hands image is big enough for everybody to see the movements.
Yeah.
Okay.
I think it's very clear.
Okay.
It's perfect now.
Okay. And other thing is that we were planning to do a patient without like a relatively normal anatomy, but there were some other issues, so we have to switch the patient. But we'll go ahead and present the case.
Okay, Assalamu alaikum. I'm Dr. Asma Yasin. This patient is 65 years old male with history of abdominal pain and jaundice. However, the background history is patient has history of left mandibular melanoma in 2022. Then patient had recurrence in 2025 April. He underwent wide neck excision for the lesion, and in July patient presented with jaundice. At that time CT cap was done which showed a pancreatic head mass measuring 2.4 into 2.6 centimeter with dilatation of CBD and pancreatic duct, intrahepatic duct, sorry. ERCP was done on 11th of August and we placed CBD stent. Cholangiogram at that time was showing distal CBD structure. Currently patient is here for EUS plus FNB.
Okay.
Thank you.
So there is a stent that going to create a little bit of artifact, but that should be okay. So holding the scope, this is what I call the neutral position of the scope. Holding close to 25, between 25 and 30. I already checked the balloon. We had to change the balloon because it was leaking. Linear scope. You may not need a balloon. You can do it without, but I prefer balloon in there because it gives me a little bit better apposition to the wall, and especially in cases if there is a diverticulum in the duodenum, helps me with that. So I usually use a balloon, which we put it on. It's working. Scope is working. So we'll go ahead and start that. The way I intubate the upper is esophageal sphincter is usually people go over the tongue like that, which is totally fine. Whatever works for you. ये क्या लिख कर रहा है? अच्छा. So which is totally fine, but the way I do is I kind of make a oral airway. Just I flip the scope, bend it a little bit, flip the end of the scope, go over the tongue. That helps me get over the tongue without any problem. Hits the back part of the hard palate. As soon as I hit the back of the throat, I would flip the scope. That takes me straight to the oropharyngeal area right above the upper esophageal sphincter. So that helps me basically pass the scope even in a difficult situation. So you see that how I made that U-turn on
They
that?
need to patent this.
Okay. And so this is you see that ये जरा show कर देना इधर आप end पे show कर देना, if you can see. Like the light is you see that it's towards the eyes of the patient. So I'll go above the back of the throat, and from there I flip. I rotate the scope. When I flip and then gently rotate the scope, and you will see that I should not have any problem passing through the upper esophageal sphincter. आप जरा मेरे oh you can show me. So you see it, light on कर दो. Okay. So the way I'm moving the scope through the esophagus is I'm moving gently with my hands. Look at that. That's rotating the scope, and then I'm going through the esophagus, very gently. You have to be very gentle going through the esophagus. Some elderly patients, they may have a stricture and they don't mention anything about having a dysphagia, and you don't want to just rip through that stricture, cause a perforation. This scope is the widest part. Mustafa showed that is 14.6 millimeter, almost 1.5 centimeter big. Don't pay attention to just to the tip. You need to know your scope, your accessories, their working channel, diameter, everything. And the EUS scope, linear EUS scope, especially the therapeutic one, has the widest diameter. This scope has 14.6 millimeter. So remember that it's not like a small scope. So right now we are at the GE junction. You can see that. You remember, this is what I call the neutral position of the scope. Wheels are facing up. And do you see how far I'm standing from the patient? Because if I'm right here and I do this movement, this is not going to transmit one-to-one all the way to the end of the transducer. You see there is a little bit movement there on the transducer, but not like that. Step back, keep the scope straight, and look at that, how much movement, same movement which I was doing is transmitted to the end of the transducer. This is the left and right torque. You see that, how it's happening? What I'm doing a little bit torquing there with my wrist, with my arm. If I need to do further, I can do this. I can go this way. And usually what I'm trying to stress is the left hand is the one which is going to hold the scope, control the scope, do all the rotation basically of your scope. So utilize that as much as you need to for this type of movement of the scope. Right hand is for accessories. Right hand is just to advance the scope or pull the scope and give you a little bit assistance. Most of the movements are going to happen with the left hand. Scope you're holding, your umbilical cord is resting on your thumb, between the thumb and the finger, and the handle of the scope, the wheels, they are resting on your palm like that. Again, this is the neutral position of the scope. Scope is at 180 degrees. So let's go to the EUS examination now. You see right there at the GE junction. You remember I showed that I want to suction this fluid because patient is not intubated. Once I am towards the greater curvature, I see that I'm close to those folds. I will suction and move the big wheel upwards and just gently rotate to the right. Can you put the EUS image bigger now, please? Okay. And so you see, I'm right. Remember I said once I am at the lever, I will pull the scope back to make 2/3 of the lever on the left side of the screen and 1/3 on the right. From there, scope is still basically in same position, 180, wheels facing up. The only thing I'm doing is with this big wheel towards me. That's what I did to get to that position. From here, I'll bring the scope, rotate the scope to right torque, rotating, 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 and you see that IVC came. That can look like aorta, but it's not aorta because there's a liver on both sides. You see that clearly, and it's kind of getting compressed easily. That's not the aorta. I gotta go a little bit further to the left, and that will take me to the aorta. You see that? From that area, from the stomach, found the liver, pull the big wheel towards me, pull the scope back, 2/3 of the lever is on the left, 1/3 on the right. Your scope is rotating to the right, and then from 180 degree, now your scope is at from 180 to 90 degree. That will take you to the aorta. Once you have the aorta, scope is still straight. I'm really staying away from the patient. So once I have aorta, I will gently move right and left, keep that aorta in the position until I find my celiac. You see that right there is the celiac. Everybody can see that. Salbhai, if you can have a mic and just keep confirming that.
Yes,
Okay.
we have very good.
Okay, you see the celiac. I already see the pancreas right above that, but I'm going to show you what to do with the celiac. Once you're at the celiac, my goal is to keep that at 6 o'clock position. So I will keep at that at 6 o'clock position, gently advance the scope. I'm just going to follow that celiac, and you see the left gastric coming off that. That's a celiac right there, right here. There's a small vessel coming off, left gastric. Then it's going to divide into two, and splenic already has taken me honestly to the pancreas, so I'll take that. But the common hepatic is going downwards to the liver because liver is right here right now. So I will gently advance the scope, got to the pancreas. If you look right here, This is the splenic artery, splenic vein at the bottom of the pancreas, splenic artery, splenic vein. This is the pancreas. I'm going to make our image a little bit bigger because it's quite atrophic pancreas. You see these strands in there.
This is a Pakistani pancreas.
So hyperechogenic foci are those white spots. When these foci meet together, they make strands. And strands are like those white lines, at least 8 to 10 millimeter long. And when those white lines meet together, they make circles, and that's what's we call the lobules. So if you're telling me that patient has a lobules, they already have foci and strands. So three at least criteria if we're looking at the chronic pancreatitis changes, so at least they have three criteria if you tell me they have a lobules. But anyway, that's separate thing. Here you see the splenic artery there, splenic vein there, and to look at the pancreatic duct is not very dilated, but I'll show you in just a second. Not really dilated at all. Okay. But it's somewhere there.
When you went towards the slightly
just
towards the
comes
neck,
right here, very small, but there are definitely changes of chronic pancreatitis right underneath the transducer, right here. It comes and goes. But anyway, goal is to follow that pancreatic duct, but we have a pancreas right in the center. Scope is right here. I'm right at the body. To go towards the tail of the pancreas, I'm going to rotate the scope to the right. If pancreas goes to the right side of the screen, that means I need to pull the scope back to bring that pancreas into the view. If it goes to the left side of the screen, that means I gently need to move the scope in to get to that. So what I'm getting at is, so it's going to be gentle movements in, out, right, left, to keep that structure, what I'm looking at 6 o'clock position. So that's what here, pancreas right at 6 o'clock position. I'm keeping that arrow there. So at 6 o'clock, I will move it a little bit downwards. So you can see the goal is going to be whatever structure I want to examine, keep that at a 6 o'clock position. So right here, I'm moving the scope or torquing the scope to the right. You see that at the bottom, the spleen comes right there. And pancreas then disappears right at the splenic hilum. This is a splenic hilum right here. Pancreas right there, ends right there. This is the pancreas. That's the tail of the pancreas. If I move it to the left a little bit, left torque, pancreas trying to go away from me, so I'm gonna push the scope in, big wheel towards me, rotating it to the left. You see the left kidney starts coming up, left torque, pancreas is still there, keep going, until you see that it's gonna fall down, and that's where that splenic vein right here, SMV, they get SMV right here, getting together, and portal vein. From here, if I want to really follow the portal vein, what I can do is I can move the big wheel towards me, try to keep that portal vein in the center, and I can literally follow that all the way to the liver hilum if that is my goal. And here, anybody else can comment what that is right here? Do you guys see the stent right there? Where the arrow is, that air in there?
Yeah,
so
they all think it's CBD.
Yeah, that's a C. We think it's CBD. Good. And so right here is the portal vein. What I was trying to demonstrate is, even though portal vein is so far away sometimes, but you are able to follow that from in the stomach, from where it forms all the way to the liver hilum, and you will see the bile duct on the other side, especially in skinny people. You are able to see the bile duct on the other side of the portal vein. But the goal here was to look at the pancreas. This is the portal conference right here. You see we are coming this way. Right there is the small duct right there. It falls down. But anybody appreciates anything else in this area at the bottom? What do you think? What is this? Right here. You see, there is a mass right here. This is the head of the pancreas. Basically, we're seeing the pancreas, majority of it, including the mass in the head of the pancreas from the stomach itself. So if your transducer is following your commands and is in the right position, you should be able to see a lot of structures from one area as well. From the stomach, basically we're able to see here SMV, we saw the splenic, we saw the portal, we saw the bile duct earlier, we see a mass in the head of the pancreas. So your neck is basically falling right there. This is the neck area because the confluence is right here. So the duct should be falling all around here. This is interesting because this, even though there are changes of, some changes of chronic pancreatitis post-obstructive, but it's not causing a pancreatic duct dilation, which is okay. And I think it possibly could be a metastatic. Have we done a FNA of this or no?
Which,
Okay.
what are you talking about, the mass?
Yeah.
No, this is, you're doing it first time.
Okay. So this may be a metastatic melanoma on it.
Yeah, that is what they wanted us to rule out.
Yeah, and that can explain lymphoma, metastatic melanoma. They sometimes don't cause enough obstruction of the pancreatic duct to cause a distal pancreatic duct dilation. So I think it's probably going to be the melanoma. Okay, and this is the duct. I think I pointed that out earlier.
While you have parenchymal changes of pancreatitis, chronic pancreatitis, so the ductal changes aren't there. And
Ductal changes are not there. As you mentioned earlier, you remember when we started doing EUS in 2012, I think it was 20. I thought initially that every patient basically have at least 3-4 criteria of pancreatitis. So I think it's a different pancreas in this part of the world as compared to the Western population.
Yeah, that when I came back and I started, I thought everybody had pancreatitis.
Exactly.
So chronic features of at least parenchymal features, but the ducts.
I don't want to get away from this discussion, but what I want to stress is that not everything which is applicable to the Western population is applicable to the Eastern population. That includes sphincterotomy and sphincteroplasty. Saad, you know what I'm talking about. So
I get that, Khalid, and I think it's a very important message.
Yeah, so it is really, same thing goes to, like, we have so many colon polyps in Western population that we have a screening program. Every patient, like in above age 40, the risk of having a colon polyp is 30%. Above age 50, average minimum 35%. You don't find that in Pakistan. You don't find that in India. So you cannot apply everything which take from one place to a set of population to the other set of population, at least a different hemisphere. So just keep that in mind. There's going to be variation there, and there's not going to be everything applicable of patient population. So here, anyway, going back to that, here this pancreas, the melanoma, lymphoma, I don't think they cause enough obstruction. They're not like an adenocarcinoma, enough obstruction to the pancreatic duct for it to get dilated and have a major parenchymal changes. Because amount of pancreas right here, it was a little bit atrophic in the body tissue, but here it's a nice pancreas, especially in the neck area.
We saw a glimpse of there is a pancreatic duct.
Exactly, that's what I was pointing, that right there you see a nice pancreatic duct right there. It's not dilated, definitely, and the image is bigger too. I have made the image bigger. But on this portal vein here, the neck area there, and in the head you see the mass itself. So now moving to the next station, can you make the endoscopy image a little bit bigger, please? And EUS there, good. मुझे पानी का दोगे? पानी की बोतल, okay. Okay, so now I'm back. What we did is we have looked at the neck, we have looked at the body, we have looked at the tail, we have looked at the portal vein. We have looked at the celiac artery, its branches. SMA was below that. I did not point out, but you guys saw that. It was right there. So, and we have looked at the left kidney, spleen. These are the structures. We wanted to take a look at those from the stomach. And we also saw the head of the mass in the head of the pancreas from stomach. So now scope is... Thank you. So scope is again in neutral position. If you look at that, wheels facing up. I'm going to gently advance the scope, going towards the distal body and suctioning the air out. Suctioning the air out. You see where the pylorus is? That's the lesser curvature. So what I'll do is I'll move the big wheel towards me, and that's really is not giving me enough movement to move the pylorus downward. If, however, I do the small wheel towards me, that might give me a little bit better direction at the pylorus. Remember what I was talking about? It's not just the big wheel. Sometimes you have to do the small wheel too to get to the pylorus. So right here, look at that, how that made it easy doing the right movement basically. So now I am into the duodenal bulb. I see the duodenal apex. My goal is to put the transducer, big wheel towards me a little bit, put the transducer right into the duodenal apex, right here in the left upper corner. अब बड़ा कर दो उसको image को. Suction. Look at that. We are right at the mass, and you see the bile duct. You see the what I'm talking about, the bile duct itself. Right there is the bile duct because the stent is there. PD is right underneath. I was talking about you will get one of the three structures, and sometimes two of the three, and sometimes all three. In spite of having a mass here, we are able to see the mass in the head of the pancreas, portal vein, and you see the bile duct right here, and pancreatic duct is hiding there. So same movement, big wheel towards you. I'm sitting in that position, suctioning. I will move the scope gently in to oppose against the wall. That stabilizes me right there. Now, if I have to go to the liver hilum, I know there is a stent in there. There's a bile, the bile duct kind of decompressed, but we clearly see the bile duct right there. To go towards the liver hilum, I'll stay in this position, start moving to the left. You see the portal vein is right there as well. Portal vein, you see that here. Who is going to tell me which branch is this? Is this splenic or SNV? And this one?
This is first SMV.
This one is the...
That's SMV.
And this is the...
This is splenic.
Yes. What happened? Switched. So what we mentioned about that earlier. So now head is here. Pancreatic duct is going to come around the portal vein, go right here. Neck is going to be somewhere, body end is going to be somewhere here. Neck is right here, and the tail is hiding somewhere there. So right now, let's pay attention to the bile duct only. Bile duct, I will keep that at 6 o'clock position. And you see that how it moved away? I gently adjusted my scope and came back using a suction. It moved away towards the op. So if it's going to keep doing that to me, I need to do something different than what I did earlier. So what I'll do is right now, I will move the big wheel away from me and see if that helps. It did help a little bit. Right there is, right there, big wheel away from me. You see clearly the stent, control of the scope, and gently advance the scope a little bit, moving the big wheel away from me, and that really I can get to the liver hilum. You see the stent there? I will move the big wheel towards me because I gotta go back to the ampulla. You see the whole stent right there. That's the air in the stent. Moving it to the right, and pulling the scope a little bit back because it was moving me away. So I pulled it back until I get to the head of the pancreas. And now move the small wheel a little bit towards me to get into the position. What I'm getting at is I'm only using my right hand only to move the scope in and out. All other movements are happening with my hand. I'm controlling both wheels, not lock any of those wheels. I'm controlling both wheels with my thumb. When I need to use move the small wheel towards me, tip of my thumb is controlling that. If I'm using the big wheel, the back part of the thumb is controlling that for me, if you see that. So that's how you need to make your thumb strong enough to be able to control that. So here we saw the mass right there. इसका biopsy करनी है ना इसके, हाँ जी. So while they get the needle ready, we'll talk a little bit more about
Portal vein is a little
compressed.
pushed or compressed by the mass, right?
But there is a nice plane.
Yeah,
You
there's
see
a
that?
yeah,
Nice plane right
clearly
there.
visible. That's right.
So there's no involvement of the portal vein. I don't see it in any angle being involved. Actually, there is a nice plane between the wall is intact. It's compressing but not involving. So here is the PD right underneath that bile duct. If I follow the PD, now I'm going to pay attention to the PD. I'm going to forget about a bile duct. PD is right here, rotating to the left. Rotating to the left, PD is still there. You remember I mentioned about it's going to come right here and then take a turn this way, and now it's going to go around the portal vein towards the distal body and the neck. You see that how it came down right here? That's the neck of the pancreas. Portal vein, neck of the pancreas. Body is this is around the neck of the pancreas. This is the body right here, and tail would be distal to that. But look at my hand, right hand is free. So right here, pancreatic duct now following towards the head of the pancreas, going there. Now because of the mass, it's compressed, but it's right underneath, rotating the scope, trying to do everything with left hand. And look at that. Scope is stable in one position. You don't have to even use the right hand, but just with the movement of the left hand, able to do everything there and follow the duct all the way to the neck of the pancreas. So now we will go to the, we'll make the Anders view bigger. Okay. So now we will go into the second part of the duodenum. I'm looking at the medial wall, guiding the transducer towards the lumen. We see the stent there. Once I get to across the duodenal apex, I will shorten the scope just like we do in ERCP scope position. Now my scope position is right here, wheels facing towards me, because that's the main position I can get. I will straighten the scope, pull it back a little bit. I want to see where that stent is right there. I want to make sure that I don't grab the stent with my scope. Sometimes it can get hung up on the scope, so we'll try to avoid that. That's where my papilla is. I will get my papilla. I got the transducer to the left of that stent. Suction that. My transducer is couple of centimeter. Couple of centimeter. Papilla. Rotate to the right and left, and pull the scope a little bit back. My goal is to get the aorta in this position, which is on the left side of the transducer and in the landing position. Now scope is very straight right here. If I go to a left torque from there, you see the IVC right there coming on the top. And if I go further to the left, either I will see the liver or the right kidney. In this case, we saw the right kidney. IVC on the top compressed. Aorta, from aorta will go further to the right. You start seeing the pancreatic mass. I need to pull the scope a little bit back because my ducts are right here, but you see the stent right there. And if I go further, right there stent, if I go further to the right, should see the PD right at the bottom. If I keep going to the right, you see the mesenteric vessels at the bottom now. Splenic, mesenteric vein, superior mesenteric vein, and superior mesenteric artery. Once I have seen that, at least I'm at the unsnare process now. But if I need to still go further to the right until the pancreas disappears, and now I have seen the whole pancreas. Now coming back, right here, uncinate process, going further to the left, head of the pancreas comes up there. There's a small lymph node as well. Further to the left, aorta at the bottom. Further to the left, IVC. Further to the left, right kidney. Now I will do this one with one hand. Kidney. Okay. So right kidney, IVC, aorta, head of the pancreas, bile duct, pancreatic duct right there. So I did all that in one position of that transducer. So again, scope is in stable position. Able to do that just with one, honestly, with one move right here, just doing like that, just with my shoulders and wrist. Back and forth, and scope is in a very stable position. From here, the stent is a little bit into the duodenum because the duodenal lumen is here. So what I'll do, those air columns in the stent, I'll move it a little bit away from me so I can see the papilla. So right here, stent is right there. You see the duodenal lumen. This is the wall of the duodenum right here. So ampulla is right where the stent is, right there. This is the ampulla right here. Because I see the wall, muscularis propria right here falling down. So from here, what I'll do is, I'll do that one move which I showed earlier, coming back, keeping the pancreatic duct in view right here. The bile duct, pancreatic duct right here. Now, I never lock my wheel, but if I have locked it for any reason, the D2, when I pull the scope back, I want to make sure my wheels are unlocked because I don't want scope to get hung up around the duodenal apex and cause trauma to the duodenal wall. Right now, gently, while keeping that pancreas in view, gently, pancreas is still in view, gently pulling back. Now I fell into the stomach, but I still have the pancreas with me. And just from there, big wheel towards me, you see the spleen right at the bottom, going there, and that all the way to the tail of the pancreas. From there, right there, again, all the way to the mass there. So what I'll do is, right now, we will go to the duodenal bulb and do a biopsy of that mass. Needle ready? Yeah. Okay. Saad bhai, any question, comment?
We're just waiting for them to tell. Anybody, any questions? Everybody is mesmerized, I think, at the moment, with the demonstration. So, Khalid?
Ji?
What's your practice for doing F&B?
Are you asking me for the needle, or are you asking me how I do it? These are two different questions.
Do you do it?
Okay.
I'm not going to ask the needle because, I kind of know it anyway.
Okay. So, needle, that's a FNA, FNB separate talk. This is a this is a acquire needle, 22 gauge FNB needle. There's a Charcot needle. There's an Olympus needle. There's a Cook needle. All those needles out there. Whatever you have access to, use that and make it work. It will work eventually. You just need to find out a way how it's gonna work. Needles. Some needles are a little bit better than in certain regards, but this is a FNB needle. Should work really well. I put the needle onto the scope. One other thing, people don't understand the mechanics of the needle, especially the wheels itself. You see, those wheels are to the right of me, my hand, so I can easily unlock and lock those. Many times I've seen people struggling because it's on this side or it's on this side, and they're trying to struggle with that. The way you avoid that is, in pretty much every needle, to some extent, when you put the needle onto the scope, it's nicely rested on the scope. wheels, as long as the wheels are facing towards you, and then you put the needle onto the, lock the needle onto the channel, it makes 3/4 turn, and the wheels come to the right side. So you don't have to struggle and go behind and try to open or close that to make the things easier. So the engineers who made these needles, they are pretty smart, and they made it, but they forgot to tell people how to put that onto the scope. So that's how you do it. It's like they are usually between 1/2 to 3/4. If you use a shark core, usually it's 1/2, between 1/2 and 2/3. But this is the of the circle, and it will come to the right. Other thing is, in this one, sheet usually is already comes lock at 1 or 2, which is fine. But if the mass is a little bit away from you, don't see the sheet, I usually unlock the wheel. I want to really get the sheet out of my scope right there. You see the sheet there now? And this is not always one-to-one movement, but right now it's sitting onto the wall, that sheet. I'll make sure that I lock the sheet wheel or lock, because you don't, when you're doing FNA or FNB, you don't want to be pushing the needle and sheet together. That would cause a lot of trauma. So I lock that sheet there. It's nicely sitting onto the wall. Now I open the needle. I'll get the needle out. You see the needle? नहीं suction की जरूरत नहीं है. किस चीज? हाँ stylus तो निकालना है. अभी निकाल लो. So you see the needle right there. इसको hold कर लो. And it's okay to ask your tech to hold it for you. You really need to hold it. What I'll do a little bit indentation of that, and what that does is that engages the mucosa of the duodenal wall. Now mucosa won't move around because the needle tip is kind of stuck into that mucosa. Once that indentation happens, now I will do FNB and stab it, what I call a controlled stab. So that is going to be, I'll put my fingers, 3 fingers at mark 4, grab that needle, actually it's at mark 3, and then gently stab. You see that, how controlled that? I wasn't looking at that, but I know that it needs to be how much it's going to go in, couple of centimeter in there. So once that happens, it's FNB needle. I'll go straight to the other end, pull it back. In one place, I don't go more than really 2 with the needle. That then just leaves a trail of blood in there. So I'll lift the wheel twice in that area, scanning. Then I do not come out of the mass. So big wheel towards me to go into the different area. You want to come to the edge of the mass, but don't want to come out of the mass. So usually, I honestly 3, 4, sometimes even that should be good enough. So I think it should be good enough in there. Once you pull the needle out, make sure if you are using the elevator to guide the needle in different direction before you pull the needle out of the mass, make sure that elevator is unlocked, and then just quickly pull that out. Make sure you lock it, the needle, before you hand it over to your tech, and then we'll go ahead and express that onto the slide. Okay.
Thanks, Khalid. Excellent demonstration. Khalid, one of the things that you just mentioned about the needle sheath, the catheter, I think it's important to actually sometimes when you're trying to insert the needle, especially in T2 or slightly odd position, scopes turned or more flexed or whatever, and if you feel that there's a resistance to the needle as it comes out, it's important to actually see where your sheath actually is. So it helps if you pull back. If you feel resistance, stop, pull the needle back, push the sheath in, see if it comes out nicely, keep it out a little bit, like and then actually insert the needle. Scope damage can occur because of the needle puncturing the sheath. Now,
Wasim, tissue hai? Oh, अच्छा अभी नहीं निकाला. So for FNA needle, you need to do multiple passes and what we call a fanning technique. 3-4 in one area, change the direction to go into the different area, change the direction, go into different area. You can change the direction different ways. Sometimes using the wheel towards you or away from you. Other times using the elevator up and down, that will take care of it. Sometimes moving the scope in and out, or even moving the small wheel away from you or towards you, that will take you into that different parts. So there are so many different ways to do the fanning, and use the one which is gonna least destabilize your scope. So is it a elevator, wheel? Usually those are the ones which are gonna help you the most, but make sure that it's not gonna affect your position too much. हाँ जी और लूँ ओके जी नहीं नहीं जरूरत नहीं तो स्लाइड पे आया है okay. So if you don't get enough with the without suction for the solid masses, you can always use suction, but that sometimes causes more blood in the specimen. So I try to avoid suction, but sometimes I can use what I call a intermittent suction. इसको hold करना है? हाँ जी.
Arif, there's a question or a point here. Doppler before inserting the needle.
So you can use it, but I literally don't see any major vessel in the way. So, but
Yeah,
I think it's
that's
a
what-
good
That's what-
habit.
But for your earlier stage or when you started doing things, I think it's important to do it. Again, sometimes, Khalid, you have to come out of the tumor to actually get change the direction. Sometimes, so if you have to, then you can come out.
Yeah, you can come out, but I
But
think
it's best. It's best,
best
especially
not
if you go
to.
especially if you have suction on, then you don't want to come out of the growth. Okay?
Yes,
If you want to come out, then you have to lock your suction, and then go back and get in, and then open the suction. But when Khalid was doing the first one, he was obviously not using any suction, and so there was no need to.
So वसीम कह रहा है कि जो है ना स्पेसिमेन ठीक नहीं किया आपने तो कहता है मुझे सक्शन यूज करो. But he's not happy. He's very unhappy over there in
No,
the
it's very
corner.
difficult to make him happy.
Yeah, I
Khalid,
know.
don't worry, ignore him.
Okay. No, no. That's what I did anyway. So, other thing I did is I used the suction, but I did not use the full suction. What I mean by full suction is, I should say continuous suction. I did not use the continuous suction. I used first I did few passes without suction, and then I did few with the back and forth with suction, and then I closed the suction
Khalid,
again. Gee.
There's a comment from Nadeem, and this being melanoma, the cells or the tissue it's less likely for the tissue to come as a full core because the cells are not cohesive.
Yes, correct. So,
And also now when you've gone in, Khalid,
Gee.
and you've applied suction, from here it looks like some of the tumor area has turned a little white, right? So now that you're applying suction, what do you do to avoid, or how do you go about actually doing the second pass?
So here, the white areas, sometimes there could be a blood in there, and it could be other thing is like there are white and certain black areas. There is a necrosis of that tissue. It's just there is a vasculature around it. You see that, and sometimes it's honestly better not to even see those vessels and not put a Doppler. Just make you nervous. But if it's a big vessel, you don't want to go through that. But in this case, still, I don't think it's going to make a major difference. I still will go into, if I need to make a third pass, I still will go right here, which is the easier part, then change the direction big wheel away from you.
Khalid,
goes-
in terms of, your preference is dry suction?
dry suction,
or
yes.
wet suction?
No, dry suction. I use on,
And what about the slow pull?
we can do that. I usually don't use a stylet, but you can do the slow pull with the stylet. What that does is like that kind of creates a vacuum, but that has to be coordinated with the tech. So when you go in, your tech pulls the stylet back. You go in and they keep pulling it back, but that needs to be pulled back when you are going into the mass.
So I was just going to comment that.
So
sometimes-
finally, I think he's quite happy with this one now. It's quite a bit of tissue there. You see the white?
Wasim? Yeah, we can. And
Yeah.
Wasim, can you take it to the other room? I know you उसका वो बना रहे हैं आप?
मेरा नहीं सर।
हाँ?
जरूरत है।
Slide बना रहे हैं? But I also want to see macroscopic उसका जो हमारा exterior.
Should we wait or we are? It looks like.
I think we are okay.
Okay, sounds good. So I'll just pull the scope out. छोड़ दो, just make sure all wheels are unlocked and same way we did before. And these melanomas, sometimes they bleed a little bit too. I think, but the bleeding is gonna stop. It's just a little bit, not much. That looks okay. Okay. Good. Thank you. Good. इसको बंद कर दें.